I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm here in London at the Annual Congress of the European Society of Cardiology 2015, and I'm discussing the CIRCUS trial. And for that I welcome Michel Andize from the Claude Bernard University in Lyon, who is the primary investigator, and Karin Przyklenk, who is from Wayne State University in Detroit, who is the discussant. Welcome. So, Michel, how did you come up with your trial? What was the background behind it? What was the scientific question?
The rationale for the CIRCUS trial was reperfusion injury. Mm-hmm. We know that in patients, the final damage to the heart is in fact the addition of an ischemic injury and a reperfusion injury. But there is nothing in clinical practice to prevent reperfusion injury. And on the other side, the experimental evidence has been quite strong regarding the mechanism of reperfusion injury, and we know that some mitochondrial dysfunction may be involved, and we know that some drugs may prevent this, including cyclosporine. So years ago we performed the first phase 2 trial in which we showed that cyclosporine was able to reduce infarct size in STEMI patients. And based on that, we wanted to build a larger trial, a phase 3 trial, the CIRCUS trial, to examine whether cyclosporine was able to improve clinical outcome in STEMI patients. Right. So that was the rationale.
So the reperfusion injury obviously is mainly in STEMI patients. Mm-hmm. And initially in your New England paper, you measured the infarct size with troponin and CK.
Yes.
And so this was like a surrogate endpoint, and now you move to the clinical.
Exactly.
And what was the design of the study?
Well, the design was a classical design. It was a randomized, placebo-controlled, blinded trial comparing cyclosporine with a placebo. And we selected anterior STEMI patients coming into the cath lab, and after randomization they received one single injection of cyclosporine prior to reperfusion, and then they were followed up for 1 year. And we measured clinical events and hard endpoints, of course, but also LV remodeling as part of the primary endpoint by assessing LV volumes initially and at 1 year, and comparing the increase in LV and diastolic volume.
And you used echo or MRI?
We used echo.
You used echo, yeah. And what was the dose of cyclosporine?
We used a dose of 2.5 milligram per kilo IV injection, intravenous injection, bolus injection. The important aspect being that we injected cyclosporine before reperfusion. That was
just when the sheet was placed?
Yes, exactly, and prior to stenting and dilating or thrombus aspiration.
Right. Well, good. And so what were the results?
Well, the results are disappointing, in fact, and surprising, because whereas we had very positive results in the prior trial, the results for the CIRCUS trial are negative, meaning that there is no significant effect of cyclosporine on the primary endpoint, and also no evidence of effect of cyclosporine on either of the single component of the endpoints: cardiovascular death, heart failure, stroke, acute MI, etc. So it appears that in contradiction with the previous trial and the preclinical literature, in this trial cyclosporine was not efficient to prevent hard endpoints.
So it's a neutral trial, not a negative strictly, but of course you're disappointed, I understand. The statistical power was appropriate. You don't think you randomized almost 1,000 patients, I read?
Yeah, right. We randomized almost 1,000 anterior MI patients. We choose this high-risk population to have, of course, the high rate of adverse events, and the statistical power was adequate to have a primary endpoint. Of course, this was not a mortality plus heart failure endpoint only. We included soft endpoint, functional endpoint like LV remodeling. But the pre-specified sub-analysis showed also that there was not even a trend on cardiovascular death or heart failure in these patients. So,
and even the remodeling alone wasn't.
There was no effect on remodeling, no effect on volumes, no effect on LV function. So it was safe, of course.
Yes.
But there was no positive effect.
So, Karin, you're the discussant. What are your thoughts about it?
Well, also obviously disappointing and surprising. I mean, as Michelle said, there's a wealth of molecular evidence that's implicated the involvement of the transition pore in reperfusion injury. There is certainly solid preclinical evidence, not unanimous, but overwhelming majority implicating the involvement of the transition pore and indicating cyclosporin should have been effective, and obviously the phase 2 trial being positive. I think the big picture question is obviously why, and I think it speaks to the long-term challenge of trying to identify an agent that will effectively treat reperfusion injury, and the challenge of delivering a drug at the time of reperfusion that will reach the appropriate subcellular target rapidly enough to affect a positive outcome. And unfortunately, that doesn't seem to have been the case here.
I have done many interviews on this subject with many drugs, and they're all neutral. So is the whole concept of reperfusion injury wrong?
I would not say it's wrong. I would hope it's not wrong. But I do think tackling this problem pharmacologically is a challenge, because it is an issue of delivering an agent within really the first seconds of reperfusion, not only to get into the risk region, but also into the cell, to the mitochondria, to cyclophilin D, the molecular target, to affect the inhibition. And I do worry if that's a realistic challenge for any drug.
But wouldn't you expect in reperfusion injury that the access to the tissue is actually better than in a completely intact myocardium?
That's certainly possible, but again, we have no idea of what the effective dose or concentration needs to be at the site of action. Mm-hmm. And since the reperfusion injury happens so quickly, the time frame is very, very short.
So that leads us to another question. What about the dose? How did you select the dose? And was the dose appropriate?
That's a fair question. We selected the dose based on 2 points. First, the previous phase 2 trial was efficient in terms of infarct size reduction with the same dose. And with cyclosporin, as you know, it's an immunosuppressive agent, so we had also a safety issue. So we basically selected a dose that corresponds to what is used in transplanted patients, what can be used ethically in this condition. So this is why we selected the 2.5 milligram per K. But the question is open now whether we should have used a higher dose.
Yes. How much was then the suppression of the CK and I think troponin at the time?
Yeah, initially we also measured by MRI infarct size, and we had a 20% reduction in MRI infarct size, yeah. which is what we based our hypothesis on for this trial. So it would have been efficient.
Yes. So what's the next step then? If you still believe in the reperfusion injury, what is the next target?
Well, there are many other targets, and we have also other phase 2 trials that are encouraging using other drugs. And I think, as Karin said, that we have a lot of experimental evidence to continue and to maybe combine therapies. Maybe a combination of conditioning, ischemic conditioning intervention plus pharmacological therapy is a way to go in the future.
Yeah, we published actually a couple papers on preconditioning that also in the surgical context that are encouraging. And so what's your opinion, Karin?
Well, I would definitely agree there. It may be naive to focus on only one molecular target. That reperfusion injury is undoubtedly multifactorial. Right. And I think it would be very attractive to combine a rational pharmacologic approach together with either post-conditioning or remote conditioning. Right. And I think those endogenous modalities stand a much greater chance of, again, affecting the target in a time frame that's relevant to reperfusion injury.
Right. Well, good. So there is lots of room for further research, and thank you very much for coming and enlightening us on this exciting trial. Thank you very much.
Thank you.